Good afternoon, everybody. Welcome to the Journal Club. Today, the topic of our discussion, the topic of the article, is assessment of maternal and neonatal COVID-19 antibodies and placental transfer ratios. I have no There were multiple authors for this article. The main author, the lead author, is Dustin D. Flannery, and the senior most author is Carilion and Polo. They are from the Division of Neonatology, Children's Hospital of Philadelphia, Pennsylvania, and they are also affiliated to Center for Pediatric Clinical Effectiveness, or CPCE, Children's Hospital of Philadelphia. So briefly about Dr. Dustin Flannery, who is the attending neonatologist at CHOP Newborn Care, and he's also assistant professor of pediatrics at Carilion School of Medicine at University of Pennsylvania. He's a core faculty member in the CHOP CPCE, and he has been a graduate of the POD program at UPenn and Master of Science in Clinical Epidemiology at the same university. His research interests included neonatal infectious diseases and antimicrobial stewardship. He has published 25 articles, and there was one related article to today's discussion was on the novel coronavirus seroprevalence among parturient women that was published just before this article. And Dr. Karen M. Popolo is the attending neonatologist and chief at CHOP Newborn Care. She is associate professor of pediatrics at Carilion School as well, and also a core faculty member in the CHOP CPCE. She had pediatrics residency and neonatology fellowship from Boston Children's Hospital, and she did PhD in medicine and cellular and molecular physiology at Tufts University School of Medicine. Her research interests include impacts of maternal immunity, perinatal antibiotic exposure, and neonatal infection on infant and childhood health. She has published about 45 articles. And interestingly, the Kaiser Permanente early onset sepsis risk assessment we use in NICU and nursery, that research was led by her as well. So they have documented that the funding was from CHOP Fodder Grant for Excellence to Dr. Kupolo, and the funder had no role in the design or conduct of the study. The journal is JAMA Pediatrics, which is published by AMA. The impact factor of the journal is 16.19 from the last year. As you know, impact factor is the average number of articles that have been cited over past 2 years. And so in 2020, the impact factor over 2018 and 19 was 16.19, which is pretty high. And H index is another index for a journal, which is like the n number of articles which have been cited n number of times. So at least for this journal, 183 articles have been cited at least 183 times. So that tells the H index. There may be more, but that's the minimum number. So why this study was performed? The infection, we know that infection with novel coronavirus during pregnancy and early infancy can result in severe disease. And we also know that neonatal protection from infection is dependent on neonatal innate immune responses as well as transplacentally acquired antibodies. Understanding the transplacental kinetics of maternally acquired COVID antibodies is important. One, for potential neonatal protection from COVID-19 and developing appropriate maternal vaccination strategies. So this article was published before the vaccination was developed. But it is very helpful in deciding the maternal vaccination strategies. There have been a very few prior works on this field. There have been isolated case reports on transplacental transmission of infection, the COVID infection as such, and only one small case series was on this topic, including transplacental transmission of SARS-CoV-2 antibodies. That included only 6 subjects, and all mothers were symptomatic. So no asymptomatic people were included in that study. So a larger study was needed to assess the incidence, efficacy, and dynamics of transplacental transfer of novel coronavirus antibodies to the newborn. The study was performed in CHOP, Pennsylvania Hospital in Philadelphia, and it was a single institution study. The study population included parturient women with SARS-CoV-2 antibodies and newborns. And the study excluded mothers and newborns with unmatched sera. So they had taken sera from all the mothers and all the newborns, but whoever matched, like mother and baby dyads, were kept, and all others which unmatched were discarded. And second of the twins was also discarded, like excluded from the study, sorry. And generalizability to our patient population is definitely there because of this ongoing pandemic and vaccination strategies that is still developing. So when was this study performed? It was between April and August of last year, right after the pandemic had started. And the article was published online in January, and then published in the journal in June 2021. And so it's recent enough to be relevant to us. The study was observational study, a cohort study, and all the parturient women were routinely screened for nasopharyngeal PCR anyway, and they also were screened for various perinatal, like routine checkups were done, including RPR, hepatitis B, C. So some of the samples were discarded, and that discarded sample was used for this study. And also the cord blood was used for studying the blood group analysis. So that sera was, whatever sera was available from the leftover blood, that was used for this study. Antibody measurement was performed for 1,471 mother and newborn dyads. And before the sample de-identification, demographic and clinical data were collected. Maternal illness severity was defined based on CDC definitions. Asymptomatic, that means no symptoms. Mild disease, like some symptoms, but no shortness of breath, hypoxemia, or radiological changes. And moderate to critical disease included either shortness of breath, hypoxemia, or radiological changes on X-ray. Antibody test was performed with ELISA with SARS-CoV-2 spike protein receptor binding domain, that is also called RBD. And both IgG and IgM concentrations were measured, and IgG and IgM concentrations of 0.48 arbitrary units per ml or more was considered seropositive. So this is the study flow diagram. A total of 1512 maternal sera were screened, and 1687 cord blood sera, and there were so many unmatched. So 1471 matched samples were collected for the study, and out of 1471, 83 mothers were found to be seropositive, and out of these 83, 72 of their infants were found to be positive, and 11 were found to be negative. So all antibody concentrations were analyzed, and geometric mean concentrations with 95% confidence interval were reported. Transfer ratio was calculated as infant IgG concentration divided by maternal IgG concentration. And correlation was obtained between maternal and infant IgG concentrations and transfer ratio, as well as transfer ratios and days between the testing and delivery. So days between testing and delivery roughly tells us the duration of infection before delivery. So transfer ratio was correlated with that as well. So what else? Statistical methods they had used. So for correlation, they had used Pearson correlation coefficient. As you know, Pearson correlation coefficient is the way to find the correlation between two variables, and it varies from -1 to +1. -1 is negative correlation, absolute negative correlation, and +1 is very strong positive correlation. Anything in between the two will be some correlation, but 0 will be no correlation. And to compare between different analytic groups, they had used Fisher's exact test, unpaired t-test, ANOVA, Mann-Whitney U test, and Kruskal-Wallis test. I will briefly tell about all those tests. And statistical significance was set at a p-value of 5%, less than 0.05. So Fisher's exact test, it is used for 2x2 contingency tables where the variables are categorical. Categorical means qualitative rather than quantitative. And categorical variables can be nominal or ordinal. So nominal means that is without any order or ranking, such as gender, blood group. So there is no one higher than the other, so we cannot do order or ranking for those. So that's called nominal variables. And especially for small or unbalanced data, Fisher's exact test is very useful. If the data is large and balanced, then chi-square test is used for the same. For chi-square test, none of the 2x2 contingency tables should have less than 5 value. So it's used for large one. And Fisher's is more accurate. That's why it's called Fisher's exact test. Unpaired t-test, it compares the means of two independent or unrelated groups of variables that are numerical most of the time. And if we are comparing the related groups, then then we use paired t-test rather than unpaired t-test. Analysis of variance or ANOVA, it is used for usually 3 or more independent groups. And again, it's parametric test. That means it is used for numerical data or quantitative. Mann-Whitney U test and Kruskal-Wallis test, they are non-parametric data. That means they use variables that are not normally distributed or not in Gaussian population. So Mann-Whitney U test can be considered equivalent of unpaired t-test. It compares the two independent groups with the dependent variable, but the dependent variable is not parametric or quantitative. And Kruskal-Wallis test is another non-parametric test which is used for 2 or more, usually for 3 or more independent samples. Again, it can be considered as a non-parametric equivalent of one-way ANOVA. So these are the tests that were used for this study. Just for a review, if we have a 2x2 contingency table, We used, and the data or variables are paired, then we use McNamara test, and unpaired we use Fisher's exact test for smaller data and chi-square test for larger data. And continuous endpoint. So if it's parametric and paired, then we use usually paired t-test for 2 groups, and if there are more than 2 groups, then we go for ANOVA. And that's 2-way ANOVA. And unpaired, if it is 2 groups, unpaired t-test, and more than 2 groups, 1-way ANOVA. And for non-parametric tests, if they are paired, we use Wilcoxon-Ranksome's test or Friedman test, depending on how many groups are there. And for unpaired, Mann-Whitney-U test if there are 2 groups, and Kruskal-Wallace if there are more than 2 groups. Please correct me if anything needs to be corrected. I just briefly read about it, so.
Well, you did a very good job of summarizing all those things. I never took statistics, so it's always.
What if you don't know so parametric is, what's another word? How do you describe that? What does parametric mean to you?
My understanding is if it is quantitative data or
it should have a normal distribution.
Yes, yes. So parametric would be a normal kind of that.
normal
Your distribution. Whereas your non-parametric is you don't have a normal distribution. So if you didn't know, you would look to do a non-parametric model for your data.
All right, so what are the results they got? Let's analyze that. So this is the table that shows different parameters based on the disease severity. So majority of the patients were asymptomatic, about 50 of them, which comes to about 60% of the women, positive women, and mild, moderate to critical. So NPA, the nasopharyngeal PCR test was ever positive in 54% of all, and only in 50% of asymptomatic patients, or asymptomatic women. So this is important because if they had taken only the serological tests and did not do any PCR tests, they might have not known how many asymptomatic patients were there. And here they have compared the reason for doing NP-PCR tests. The time between the test and delivery was pretty short in asymptomatic individuals, as we can expect, because they just came for delivery and got the test done before delivery. And whereas if they were symptomatic, the duration is longer because they were tested much earlier than delivery. So that is a significant difference. And maternal IgM was noted, and that was not different between the groups. The concentrations were also not different. Maternal IgG concentration were also not different, as well as transfer ratio between the groups were not. And so this table shows that they have compared. Sorry, go back
to the last one. Yeah. For the asymptomatic numbers intrigued me, just in the sense that so few were PCR positive, right? So of the asymptomatic, only a third actually had a positive nasopharyngeal swab, right? Am I interpreting that?
99% of that first.
Well, for the PCR ever positive.
Like in that first cell there, it's 82 out of 83.
You're talking about specifically for
I'm talking about specifically for the asymptomatic. You're saying that 49 out of 50
49 were
So
tested.
49 out of 50, yeah.
So 49
were
out of
tested,
yeah, sorry.
but only 15 of them were positive,
Yes, that's
right?
right. Yes.
Yeah. So a third of asymptomatic cases were going unrecognized by the PCR,
That's
which, but then in your IgM, over half had a positive IgM, which would suggest probably a semi-recent infection. So it just speaks, it was a little disheartening to me in terms of the fact that the PCR was, quote, missing. But it's also unclear. I think there was a huge variability in how and when the asymptomatic were tested, since they obviously weren't tested for symptoms, right?
So yeah,
But wouldn't that just speak to if you had the disease and then you got over the disease and now you're negative, that you had it in the past?
Yeah.
Isn't that what that's saying?
And the
Or
IgG is high in most of this as well.
Right.
Say it again.
The
But this
IgG
was-
is also elevated.
It was just that this was done so fairly early in the large US spike.
Yes.
And so that's why I felt like, yeah, if it was done now, I wouldn't be surprised at all to see a bunch more seropositivity from a past infection,
Gotcha.
right? But this was done pretty early on.
Gotcha.
I just found it curious, was all.
so this is comparing the maternal characteristics with newborns who were seropositive versus seronegative. So 72 newborns were seropositive and 11 were seronegative out of these 83 mothers. And as you see, there is no significant difference between the various demographic data between these two groups. But if you come down, okay, so the continuation of this table is on the next page.
What do you think about the age of your selection for your population?
Age was not different and was
Not different, but these tend to be older mothers who were selected for this study, or at least the ones that volunteered for it. I mean, even for your 75th percentile for youngest, or your 25th is 25.
yeah,
So the majority of these are older patients, older mothers,
right.
as compared to your teenage moms or your young 20s. I thought that was interesting. There wasn't a difference between the two groups, but the ones who signed up tend to be older.
Right. Similarly, the gestational age at delivery or preterm delivery was not significant, but it is intriguing. It was intriguing because we expect that the preterm delivery may be associated with less transfer of antibody, leading to more negative, more seronegative, but it was not different. However, I will discuss about that in a short while. The sample size was quite small for the preterm delivery. Then the other things were the timing between the testing and delivery was also not significantly different between the two groups. So that was maternal serosampling and delivery was not different, but the testing for PCR and delivery was significantly different between these two groups. That shows that the babies who were seronegative, those mothers had fairly short interval of infection. So they might have only IgM, which does not get transferred usually. So they were seronegative. And maternal IgG seropositivity was significantly different between these two groups. All of the babies who were seropositive also had maternal IgG seropositivity, whereas only 50%, or half of them in the seronegative group was positive. And similarly, the concentration of IgG antibody in moms, they were significantly higher in the seropositive group compared to the seronegative group. Maternal IgM seropositivity was not different between these two groups.
And does everybody think that the associations that this is saying are significant make sense, or do they agree with? Like, I think that for this page, Manish, kind of pointed out how this makes sense. But if you go back a slide, so it's saying that there's a 2% chance that multiple gestation would be accounted by random chance, aka is statistically significant.
Yeah, but there was no like 0.
But it's comparing 0 to 2. But again, I just feel like it's an important thing to think about too, that like the p-value is not the end-all be-all. I mean, I think that we have to, I can't prove this, but I would think that if you repeated this study with larger sampling, that you probably would not show that multiple gestation was a risk factor. But I don't know that, maybe it is, for having a seronegative child.
My understanding too, I mean, if you're making a number of comparisons, at a certain point, you're gonna find faulty, like basically false positives. So I think if I recall correctly, it's the Bonferroni, basically you have to account for that and have a lower cutoff for a p-value, so.
If you're comparing more things?
If you're comparing more than, I forget what the cutoff is, but more than say 10 or so comparisons, then you're gonna find something abnormal, even if it's not true.
I think that more so applies to the number of types of tests you do. When I look at this, I see that they're just making sure that between the two, there's not some confounders here. Is kind of how I see it. But you're right, you do have to lower your p-value with the more different types of tests you're doing, because you're bound to find something random that you interpret is something that's really not.
So, I don't know if these are the same infants, we don't know that, but there were 2 infants that were multiple gestation, and there were 2 infants that were less than 37 weeks. And you said that earlier, that perhaps a preterm infant might have less maternal antibody transfer. And, is that the factor that's contributing to that? You don't know that those are the same 2 infants, but it would make logical sense that the preterms are. I don't know if I'm making any sense or not, but if that could be what's leading to it.
But I think especially with topics that are sort of popular in the lay media too, you could worry that somebody could take data and sort of make some assumptions or conclusions from it that probably aren't valid. So I feel like it's
Never do that.
never mind. They never do that.
The correlation between IgG concentration in infant versus IgG concentration in mother, it's very clear that as the concentration of IgG increases in moms, the baby's IgG concentration also increases linearly.
See, I think that's your money slide right there. That's what got this thing published.
Yeah.
Is that antibody correlation right there, which is pretty decent, pretty strong.
And they also compared IgM concentration that you can see there is no correlation. It is not that's vertical line, any vertical or horizontal line have no correlation. Also, if we see the confidence interval between these two, they are overlapping to a great extent, making it not significant. And this is another graph showing the transfer ratio, that is the baby's antibody versus divided by mom's. And that ratio compared to the duration between testing PCR and delivery, that was also linearly correlated. So the transfer ratio increases as the duration between testing and delivery increases, or the duration of infection increases.
We'll look at the distribution of that compared to your other one,
Compared to
right?
this. Yeah. This one is so concentrated along the line, and this is a little bit randomly distributed. But overall trend is towards that.
Right. It's just not quite as strong. But
How do you determine that? I mean, we can eyeball it, but is there something else you put with when you're doing these type of models, a value, or correlation value?
I think there are some outliers that we have to remove, like the higher value.
The correlation.
Yes, so talk more about that.
So that's essentially going to be a measure of how far from the line each of the data points are, and then talking about kind of the average of those distances.
Okay. What is your line?
So that would be the best fit line.
It's your best fit, so you kind of your mean.
Yeah.
And then you can run an analysis on that, regression, linear regression model, which they do put in there, and they don't put it on their graphs though, but it's your R value. So they assign you a value of R to your other graph if you go back to that one. And I think it was around 0.8 or so, which is pretty good, pretty strong. That's from -1 to 1, the higher certainly better. And it looks at the variation from the mean, the best fit. A lot of studies will go further and look at the variation and account for the degree of variation, and that's more of an R squared value, which is a little bit better to do. And it's essentially you square your R value, so that puts it around, I think it was 0.88. So anything better for an R squared that's above 0.5 is a pretty good fit, especially for clinical medicine.
And Chad, the R value for that other one was 0.62.
So if you square that, you're probably around 0.4 or so, which is, they're saying weakly positive association with the other one.
It would be interesting to see too in this slide which ones were associated with disease or asymptomatic, and what severity of disease as well, if it were color coded.
One critique I had for
Seems
the,
like there is an association with the duration between, or from positive PCR or PCR test to delivery with severity of disease.
so what is it, Emily, you're asking for?
On the previous slide, it would be interesting to see
This one?
that one, yeah. Which of those would correlate with asymptomatic infection or mild or moderate or severe disease, since it does seem like any of those categories are associated with different times from test to delivery. I don't know if they have that.
They do that. They account for that somewhere, but here they've put it as a transfer ratio. What is that, the transfer ratio?
The ratio of babies' IgG versus maternal IgG.
So there's higher concentrations in some of the patients in the cord blood than the actual.
Yes. So there are so many,
mother.
there, as we can see, there are so many values above 1 here. And that tells us that there is active transfer between mom to baby. So that's why, rather than only passive, so that's why the ratio can go higher than 1.
Maybe I don't understand that. So how is it able to go higher?
And because of active transfer of the antibody from mom to babies.
I don't know.
I also had the same question, how it can go higher, but
I see what he's
could also-
saying.
I see what you're saying.
Mechanism.
Yeah, I don't know how it does it.
It could also be a concentration effect that happens
Yeah.
from the babies.
Yeah.
so
It's
maternal,
more concentrated when you're
Yeah.
sampling,
Right.
potentially.
Right.
Is an explanation for it? Okay.
I didn't find that explanation, but that was my thought too. Like mom's blood volume will be more, so concentration will be less compared to babies.
Okay.
These are arbitrary units, right?
Yeah.
Yeah.
Well, they're probably not, I think you said the samples were obtained at routine blood drawing times. So the time when the mom's sample is done and the time, this is cord blood, so that's done right at the time of delivery, that could be
All different.
days apart, right?
Yes, that's also
Yeah.
also.
And then I don't know if, sometimes with NICU studies, it doesn't matter how you sample, if you do arterial versus venous
Yes.
on cord blood, that can affect some things. I don't know if that would also be another one, but the timing is huge.
Yeah.
So I think, I don't want to jump ahead, but like if you were to design this as a quote optimal study, I would think that you would want to do routine nasopharyngeal swabbing of the moms at regular intervals and routine blood work so that you could be able to compare those. I mean, the study was designed for presumably to just, to be a little easier on the participants and collect data that was out there already.
Well, I think what Dr. Keyes has even mentioned here, that may discredit this graph then, because how do you really interpret a transfer ratio if we don't have that understanding and correlate that with the nasopharyngeal swab? So maybe there's a lot of limitations here to where we can't really draw a lot of conclusions from that.
The timing of collections are different.
Well, I'm going back to look at the study methods. It says women have blood drawn for RPR at the time of delivery. So that would be, so that negates what I just said. I'm not sure why you would,
But it would be such an unusual practice, right?
I
Wait till they're
know.
delivering?
that's what it says.
Delivery,
Um,
yeah.
Maybe they have a high incidence of syphilis. Make sure they don't miss it, I don't know.
If you look at this, it says time between maternal sera sampling and delivery. That was
That would make more sense with last
Mean
week's
of
discussion on
time.
teen pregnancy.
9 days in the seropositive and 14 days in.
Not hours.
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 Oh, sorry, hours.
So all of them were done within 24 hours,
So
basically.
pretty ready for delivery.
Yeah.
That's pretty
So
good.
did
I was wrong.
they,
Ignore what I said.
Even the 75th percentile was 28 had several conclusions. One was like maternal fetal infection of the COVID antibody coronavirus transmission is rare. That is because they did not find any infants who had IgM antibody positive. Because IgM, we know that it does not get transferred from mom to baby, and if baby had IgM, that means he was or she was actively infected. So no IgM was found, and there is an efficient transplacental transfer of IgG antibodies. Like 87% of the infants were seropositive, and transfer ratio was 1 or more in 55% of seropositive infants. So that's the only thing I found while looking for this, how it could be high, that they said that because of active transfer. And there is a positive correlation between maternal and cord antibody concentrations. Higher transfer ratio correlates with increasing duration between onset of maternal infection and time of delivery. All cord sera were seropositive if the maternal infection was 17 or more days prior to delivery. So this was very important because they need to be infected for about 17 or more days on an average, more, prior, so that they can transfer the antibody to the infant. So the strengths of this study is that they had a large cohort, and they focused on all women presenting for delivery rather than only those with clinical infection, because they might have missed the asymptomatic infections. And so that led to the observation that transplacental transfer was efficient regardless of the presence of symptoms in the mother or the severity of the disease. So even asymptomatic mothers had significant transfer. And the limitations are that it was a single-site sample collection and it was retrospective because the EMR, the demographic data and all were collected based on the retrospective review of EMR. And the number of preterm infants was small, and lack of information on post-delivery discharge outcome. So what happened to those infants who had the IgG antibody, whether they were actually protected from the infection or not, we don't know. So how does it affect us, or how is it important to us? One is that timing of vaccination, based on this study, should be at least 17 or more days prior to expected delivery. And earlier is better because placental ratio increases with duration, as we have seen with this study. We know that transplacental transfer begins around 17 weeks of gestation, and complete vaccination will take about 21 to 28 days. So to be very efficient, we should be starting to vaccinate mothers starting in early second trimester, considering that they could have preterm deliveries. One finding that I have briefly discussed before was transfer ratio was not affected by premature delivery, but smaller number of preterm infants could have affected this. And most preterm infants infant was 31 weeks, so not two preterm delivery was noted in this study. So we know that if the sample size is smaller, the confidence interval increases and the type 2 error can happen. So type 2 error is like accepting the null hypothesis when there is truly a difference. So false negative. And we assume that protection in infants born prematurely may be affected by a shorter time for antibody transfer. So studies with larger sample size and prospective follow-up may be helpful in clarifying this. Further studies may also be needed to determine if COVID-19 antibodies are protective against newborn infection, and if so, at what concentration. And also, whether the transplacental kinetics of vaccine-elicited antibodies are similar to naturally acquired antibodies. So in this study, only naturally acquired antibodies were studied. We don't know whether vaccine-elicited antibodies have similar kinetics. So further studies may be needed for that as well. So most recently, ACOG recommendations and considerations are as follows, as update from September 2021. So they have mentioned that increased risk of ICU admission, need for mechanical ventilation and ECMO, and death in pregnant women with symptomatic COVID-19 infection as is known. And pregnant patients with comorbidities such as obesity, diabetes, and others may be at even higher risk of severe illness. So ACOG recommends that pregnant individuals be vaccinated against COVID-19. And completion of the initial COVID-19 vaccination series must be emphasized, although they do not mention what's the latest time we can start vaccination. Vaccination may occur in any trimester, and emphasis should be on vaccine receipt as soon as possible to maximize maternal and fetal health. And regarding booster dose, they recommend that pregnant people receive a booster dose of Pfizer vaccine at least 6 or more months following the completion of their initial Pfizer vaccine. So only if they have received Pfizer before, they can receive the booster of Pfizer. Moderna has not been studied, so they do not recommend that. Similarly for Janssen, also they have no recommendation. So if we include booster dose as well, then we need to start vaccinating them early in second trimester to be having like efficient transplacental transfer of antibodies. So
I looked it up real quick, and it is there's obviously the passive transfer, but in humans and several other mammal species, there's in the syncytiotropoblast, I can't say that word. There's a FC receptors that essentially glom onto every IgG that passes by and shifts it from maternal to fetal circulation. So it is an actively driven process as well.
So I guess this begs the question for this study though, is this IgG acting any different than any other IgG in the body?
I don't think so.
Right.
So to be a little provocative here, I think this says what you just said. And if we're pediatricians, those egg hog, that's all about protecting women, which is wonderful, right? But what are we protecting the infant from? I mean, right? I mean, unless you guys know more than that, and you probably, I'm sure you do, but like infants really aren't really at risk from this illness much, which is interesting. And they didn't know that back then at this point, but I think infant illness is very limited.
Yeah, I mean, it's rare, but it's, there's cases of.
It can be, yeah.
So the kids don't have COVID, but they're still getting a lot of complications potentially from COVID positive moms. So vaccination could still potentially benefit.
I think we're still trying to figure this out. Maybe these guys are trying to do it. That linear correlation graph to me is what got this thing published, but you're right, the kids, the babies aren't getting sick, but, there's something to be said if this is laying some groundwork. If we get another variant that does affect young ones, then we may know a little bit more.
I have one more thing to add. Like, although they said that IgM antibody was negative in all infants, but I assume that it takes few days at least to develop IgM antibodies also, even if they are infected. So if they are just born and cord blood IgM is negative, that does not mean that they are not infected, right?
Right. Yeah, if you truly wanted to know that, you'd have to test the infant's blood weeks later, probably. Yeah.
Yeah, but infected how? Because, your first 48 hours, nasopharyngeal swabs are negative. Their lungs aren't sick, but is it something systemic going on?
Right.
Another thing to keep in mind, like with all these COVID studies, are the types of PCR tests that are being done. So it seems like from what you presented, there was only one gene being screened for that. Yeah, and so like when we developed the test at FBRI, we actually used three different ones, three different genes from a variety of the genome to make sure that we cover as many variants as possible for broad coverage. So that's, just another thing to kind of look at and see, are they capturing everything that they could be?
Possibly it was early in the course of pandemic. So.
Yeah.
Griffin, I'm thinking what you're saying.
The sampling as well is an issue. As well, negative kids that will be tested, and then a few days later they'll turn positive. And then we're using PCR as a surrogate for gold standard but we don't really have a gold standard for COVID.
Yeah.
We kind of assumed it with PCR, but we don't really have a gold standard for detection.